hope my dog doesn't bark too much during this thing. Maybe he'll go outside.
All right, I'm going to get started.
Okay.
Thank you everyone for joining us for Grand Rounds. Today we have our own Dr. Nisha Parikh, who will be talking about pregnancy and cardiometabolic outcomes, opportunities to improve cardiovascular prevention. Dr. Nisha Parikh is an associate professor of medicine at UCSF and a cardiology deputy editor at Up to Date. She is a non-invasive cardiologist with interests in cardiovascular disease prevention and in pregnancy. Dr. Parikh earned her medical degree from New York Medical College and completed her internal medicine residency at Tufts Medical Center. She completed a clinical cardiology and research fellowship at Beth Israel Deaconess Medical Center, as well as a cardiovascular epidemiology research fellowship with the Framingham Heart Study at the Boston University School of Medicine. She earned a master's in public health at the University of California, Berkeley. And she has been recognized by the AHA Council in Clinical Cardiology and honored by Merck for her clinical excellence as a woman in cardiology. Dr. Parikh's academic portfolio is vast and impressive with a few highlights, including work with MESA, determining long-term effects of hemodynamic changes of pregnancy, developing a risk score for incident hypertension in the Framingham Heart Study, and demonstrating peripartum predictors of cardiovascular disease with the Women's Health Initiative study. So we're very excited to hear your talk, Dr. Parikh. As a reminder for the attendees, please put any questions that you may have in the chat box or in the Q&A box. And if you would like to ask your question in person, just raise your hand virtually and I'll allow you to turn on your video. This video will be recorded just so everyone knows, and I'll turn it over to you, Dr. Parikh.
Thanks so much, Joyce. Okay, good afternoon, everyone. I just wanted to start by pointing out a statement that we wrote recently that was just published that basically encapsulates a lot of what I'm going to talk about in a much more elegant way that I'll probably convey today. But this document goes over the sort of vast body of evidence that supports the fact that adverse pregnancy outcomes are related to CVD, and then just highlights a lot of areas that we could use this information to better care for our patients. This is essentially the list of adverse pregnancy outcomes, or APOs, that are associated with atherosclerotic CVD, as well as heart failure. And as you could see by the strength of evidence, most of these got an A or a B, so there's a very high level of evidence that these are related to adverse outcomes that all of us are interested in. And the list on the left-hand side are things that I think should be taken in a medical history for any female patient that you have. The adverse pregnancy outcomes are also related to cardiovascular disease risk factors later after the pregnancy. So in the postpartum setting to midlife, anytime before the cardiovascular disease outcome. And you can see here as well that for hypertensive disorders of pregnancy in particular, there's large bodies of evidence that these are related to blood pressure, diabetes, and dyslipidemia subsequently. The evidence for gestational diabetes, preterm delivery, having a small baby, or small for gestational age baby, or SGA, and pregnancy loss is less robust, but it's still fairly strong that most of these do lead to classic risk factors. And this really tells us that there's a lot of opportunities for prevention of the risk factor and thereby prevention of cardiovascular disease. These were our summaries. I'm not going to sort of belabor them by reading them to you, but just to sort of point out that that there are a lot of opportunities for prevention. Breastfeeding and lactation can be protective. We'll go over some data about that. There's really important race ethnic disparities that need to be really acknowledged first and then hopefully tackled. And I'll go over a little bit of that work as well. And then finally, number 9 is important really to think about how can we leverage our healthcare systems, the EMR, to improve transitions of care for women with adverse pregnancy outcomes. And and really start targeting strategies to reduce long-term risk using what we have in a more clever way. Why is this important? Well, cardiovascular disease is the leading cause of death in women. And the coronary heart disease, or CHD mortality in women and men greater than 65, although that's dropping, and then dropping as well in males and females for the middle age, 55 to 64. Among women, which is sort of the dark line, ages 25 to 54, we're seeing really a stagnation of mortality drops, especially as compared to men in these age groups. And this caused Betsy Nabel to sound an alarm. Dr. Nabel being the past head of the NHLBI and current, I believe, still current president of Brigham and Women's Hospital. So US mothers, who fall into that age group of 25 to 45, have increasingly adverse health. If you look at maternal mortality in the United States compared to other developed countries, our rates are rising, whereas everywhere else it's dropping. So I think this is a really startling figure, actually, for a country that spends probably more of its GDP on healthcare than any other countries listed. The causes of pregnancy-related death in the United States, many of them fall in our wheelhouse. They're cardiac in terms of their origins, cardiomyopathy, even pulmonary embolus and stroke, as well as hypertensive disorders of pregnancy. These are the leading causes of death among women in the United States. There's also really important disparities by race. And this is data from California that shows that African-American women were, up until, sort of 2005, having these escalating rates of maternal mortality. And the disparity was sort of rising as well between African-American women and white women. Luckily, in the state of California, we've implemented a lot of quality measures, and our rates overall of maternal mortality are declining. So I think that's a positive story here. This has been covered in the lay press as well, and it's been a really important issue. And Joyce, our very own fearless chief resident, has tackled this in this very nice review article that I would love if you would have some time to read. That really being Black in pregnancy is a risk factor for CVD-related morbidity, mortality, and we really need more concerted efforts to improve care among Black women in pregnancy. We need studies. Most of our studies, as you'll see, are in women of European ancestry, and we need to change that so we can better generalize our data. And then we really need to tackle systemic racism in our healthcare system to really get at what are the factors that we can really address directly to reduce these disparities. So I wanted to introduce this concept, which many of you have seen. So this is sort of the classic Sitar and Greer article that tells us that pregnancy is a stress test, a cardiometabolic stress test. So if you consider that this black line is the vascular risk threshold for most men and women, women with normal, who will have normal pregnancies, uncomplicated, I should say, are in this blue dotted line. And they sort of go throughout their life with this lower risk, cardiometabolic risk profile. And then with pregnancy, you might see a blip in that risk. They'll have insulin resistance as a normal physiologic part of pregnancy, adipose deposition, changes in vascular function, et cetera. But this won't ever cross the vascular risk threshold, and that pregnancy will be uncomplicated. But if you contrast this with the population of women in red, they actually are probably at elevated risk even before the pregnancy. And during the pregnancy, their sort of blip crosses that vascular threshold. So they might have gestational diabetes, preeclampsia, or one of those adverse pregnancy outcomes. That means that they sort of have this positive stress test. That's really the analogy. And they go on to have cardiovascular disease at an earlier age than women with that lower vascular metabolic risk. And so I think all this information really tells us that there are a couple places in the prevention paradigm that can be leveraged. And they might be right now a missed opportunity, because I think most of us in our practice don't end up taking a pregnancy history when we see our patients. And we don't take a a history, like a birth history either. It turns out that all these adverse pregnancy outcomes that I mentioned, if you're born in a pregnancy to a mother that experiences those, or if you yourself as a baby are born preterm, then you're actually at your own elevated cardiometabolic risk. So there's really two individuals that can be targeted within this paradigm. So this is really what this slide is trying to hammer home, that rather than approaching the woman after the reproductive period, we should really be thinking of women in their reproductive periods at risk, and we should understand their risk factors to help them prevent the onset of those things. So there's really, the way that I've sort of looked at this over the last, over a decade I've been studying it, is that this reproductive period encompasses fetal outcomes, maternal outcomes, pregnancy, and reproductive period and pregnancy. So it's sort of this, you could think of it like this, like an onion, and there's many layers to it. The statement that we wrote really only addressed the fetal and maternal outcomes, but there's also a lot more to it. And I'll try to at least give you a little bit of a highlight of that. I also think of these factors as a Venn diagram, because many of these reproductive factors will intersect with maternal adverse pregnancy outcomes, numbers of pregnancies, and fetal outcomes. So many of these are either negatively or positively correlated with one another. And the factors listed on the slide have all been linked to cardiovascular disease in some way or the other in women, in either a positive way, most of them with a positive relationship, and some of them protective. So first I wanted to talk about pregnancy. I think we went over the physiologic changes that can happen in pregnancy. Hemostasis and coagulation are another important one I didn't mention that can lead to cardiovascular disease. And there's also a lot of hemodynamic changes in pregnancy, including very stark changes in hemodynamics of preload, decreased afterload, and shunting to the uterus and placenta. Oh, I should say there's also an increase in LV mass, about 30% throughout the course of pregnancy. And traditionally, pregnancy is thought of as a physiologic hypertrophy, similar to exercise, so sort of like kind of adaptive, normal, quote unquote, response. But we wanted to challenge that notion. So we looked at number of pregnancies and cardiovascular disease among 1.2 Swedish women using the population registers, and found this J-shaped association that had been described before. This was just larger numbers, and we're able to adjust for things that hadn't been before. The nadir of risk was at 2. So all those physiologic changes sort of manifest in some way or the other in cardiovascular outcomes. And we recognize that this could certainly be a result of confounding as well. We didn't perfectly adjust for things. We also showed in MESA that different cardiac remodeling parameters, including volumes and diastolic and systolic, increased with an increasing number of pregnancies. EF declined, and these were women in their midlife, and this was cardiac MRI. So this is the number of pregnancies she had, and then sort of the least mean squares of these factors. And LV mass also was increased with number of pregnancies. The electrical conduction system might also be permanently changed with each pregnancy. So if women in Women's Health Initiative described 5 or more live births versus 0, she had a 1.32 millisecond increase PR interval. So maybe that's not like a whole heck of a lot, but I think on a population level, these are like subclinical changes that maybe might lead to some population level changes. There was also changes in the QT interval. And finally, this was work by Philip Hall, who was a fellow many moons ago now, and now an interventional cardiologist in North Carolina. He showed in the Women's Health Initiative also, interestingly, that nulliparity, having 0 pregnancies, was associated with HFpEF, almost a 3-fold increase of HFpEF. And we don't know why this is, but this is also interesting. So pregnancy per se is related to cardiovascular disease, myocardial remodeling, and electrical remodeling. So I'm going to sort of jump to some of the other parts of this Venn diagram of reproductive factors, pregnancy, and fetal outcomes. Pregnancy loss is probably is another, I should say, adverse pregnancy outcome that's linked to cardiovascular disease. This is work from Donna Parker, who's in the WHI as an investigator, and she showed that pregnancy loss was related to CVD and WHI. This is a slide by Dr. Hall, and he also sort of looked at the literature. There is evidence that pregnancy loss related to CVD, but it's not an entirely consistent story if you look at the prior evidence. And what he showed is actually that many of this much of the association, I should say, between pregnancy loss and CVD and the Women's Health Initiative could be explained by sort of increased levels of cardiovascular risk factors, such as higher BMI, hypertension, diabetes, dyslipidemia, et cetera, in women who have pregnancy loss versus don't. So, and it might even sort of exist before the pregnancy. We looked at the time, back in 2016, all of the reproductive factors that we could in the Women's Health Initiative to sort of see which ones are the most important factors if you sort of look at them all together, since they're probably correlated. And we found that if we looked at a number of reproductive factors, we didn't really have adverse pregnancy outcomes at that time. Early age at first birth, number of stillbirths and miscarriages, having irregular menses, and a lack of breastfeeding for 1 month were related to coronary heart disease. This didn't really move the C statistic all that much. If you looked at the model with established risk factors, so it's kind of like our ASCVD or Framingham risk model, the C statistic was 0.726. And then if you added all of the reproductive factors, we really only moved like a percentage point to 0.73. So this didn't really move model discrimination very well. But those were the factors that at least were independently associated with coronary heart disease, even when accounting for established risk factors. The breastfeeding story is pretty cool because it's something that we counsel anyways. We're not always so great at helping women with, but it definitely reduces CVD risk factors in women later in her life, as well as actual outcomes, so cardiovascular disease and stroke. And this is work by other groups. And now on to the adverse pregnancy outcomes. So I just wanted to go over a little bit about the pathophysiology of an important adverse pregnancy outcome, which is hypertension in pregnancy. We think that some of the abnormalities occur at the placental maternal fetal interface, or the decidua. This is basically a decidual spiral artery that is implanting into the myometrium, or the uterus. And so the decidua is the part of the placenta that's closest to the mother. And then here's the uterus, or the myometrium. So in a normal situation, which is on the left-hand side, you have a deep implantation of the spiral artery, and you have sort of normal growth of trophoblasts and angiogenesis. But with preeclampsia, you actually have this shallow implantation, and those arteries don't get in, as the growth sort of doesn't occur deep into the uterus. And we believe that sets off a cascade, including inflammation, oxidative stress, as well as a bunch of other abnormalities. This is a placenta from a hypertensive pregnancy, and you can see there's actually an infarction in the placenta that looks similar to the infarctions in the heart. Okay. This is decidual artery medial hypertrophy, which is very much like what our arteries look like with essential hypertension, with that increased smooth muscle. And there's also the sort of maternal pre-pregnancy factors that predict the onset of hypertension in pregnancy, including chronic hypertension, excess BMI, psychosocial stress, diet, as well as family history and genetics. And if you look at the umbilical artery Doppler in severe preeclampsia that causes growth restriction, you can actually see a blunting and an absent end diastolic flow, on that Doppler. So there's actually abnormal blood flow to the fetus as well. And so that's why fetal growth restriction is a marker also of vascular dysfunction in mom. There's also paternal factors that predict preeclampsia, and these haven't been all that well studied, but I think are also really important as well. So it turns out that in the father's mother, if there is preeclampsia, he's more likely to have a partner that develops preeclampsia. So I think that's really interesting as well. Preeclampsia is probably the most strongly related to CVD in terms of all the adverse pregnancy outcomes, and the most robustly so. There's about a twofold increased risk of cardiovascular disease and a threefold increased risk of developing hypertension after having a pregnancy complicated by preeclampsia. Preeclampsia often comes along with another important APO, gestational diabetes. This is a costly condition. We spend about $1.3 billion a year on it, and it occurs in about 2 to 8 pregnancies. This is a more recent meta-analysis that shows that gestational diabetes is related to cardiovascular disease with like about a twofold increased risk. And if you account for the onset of type 2 diabetes in the interim before CVD develops, then that relative risk is 1.56 if you look across studies. So it's still elevated, even if these women don't develop overt type 2 diabetes, there's still increased risk. A little bit about specific fetal outcomes. So this is also data from the Swedish population registers, and we essentially showed in here that having a very small baby born very preterm gave a woman a threefold increased risk compared to the term infant who was born not small for gestational age, but normal size for gestational age. So some of these, this is really just to illustrate that many of these interact with each other. And this was actually an association that met the criteria for effect modification. So these two together are worse than sort of one by itself. And this is work by one of our fearless chiefs, Jackie Desjardins. She looked at placental abruptions and their association with heart failure in 1.5 million women in California. Found that placental abruption occurs about 1% of the time, so it's not as common as some of the other APOs. But over about a 5-year follow-up, placental abruption was significantly associated with heart failure, with about a 40% increase hazards of heart failure. And if one had a hypertensive disorder of pregnancy, this actually modified and mediated. That means that it sort of made worse that risk, but then it also was one of the mediators of the risk as well. And in the Women's Health Initiative, after the original inquiry we had done in 2016, we were able to send the women this survey that had 5 short questions on adverse pregnancy outcomes of hypertension, gestational diabetes, low birth weight, and high birth weight. This was sort of our flower Venn diagram that just showed that many women had more than one over the course of their reproductive period. And these were sort of the number of APOs that we're able to ascertain in this cohort. This was a publication by Mark Sondergaard, who was a DARE fellow. That's the Danish American Research Exchange. So this is 5 med students that are selected to come to the Bay Area and either work with someone at Stanford or UCSF or both. And he worked with 2 of us, Dr. Latke at Stanford, as well as myself, and was able to have this nice publication on that data. And basically among 46,000 women who responded to our survey from the original WHI cohort, he showed that all of the APOs were in unadjusted models were associated with later ASCVD. However, once we adjusted for established risk factors, having a high birth weight infant was not significantly associated with CVD. Hypertensive disorders were sort of most strongly associated with CVD. And essentially, we sort of confirmed findings that had been from before, but these were now older women. These were very postmenopausal women in their elderly years, many of them. And so it was interesting that the relationship was still there, even though so many years had passed since her pregnancy. This is work by Alexander Hansen, and he was another DARE student that came and worked with us. And his work was just accepted to JAMA Open Network. He looked at adverse pregnancy outcomes in heart failure in the Women's Health Initiative. And this data set had less women because we had to merge it with adjudicated heart failure data set in WHI, and yielding only about 10,000 study participants. And he was able to show, interestingly, that not only was heart failure associated with, not only was hypertensive disorders of pregnancy, that's HDP, associated with total heart failure with about 1.75 odds, and red is sort of the fully adjusted model, but that whereas HFpEF was associated with HFpEF with about a twofold odds, it was not significantly associated with HFrEF. So it might be that much of this is sort of diastolic or, sort of HFpEF, the association between hypertensive disorders and later heart failure in women, which isn't so surprising knowing the prevalence of HFpEF in women is higher than in men. And he also did a very nice mediation analysis that showed that if you looked at sort of causal mediation, hypertension, body mass index, and coronary heart disease mediated much of the association between hypertensive disorders of pregnancy and later heart failure, whereas diabetes did not mediate much of it, just 1% of that association. So often this is sort of the question that comes up. Well, what comes first, the chicken or the egg? Are women at higher pre-pregnancy risk? Is that explaining the entire thing? And sort of who cares about the pregnancy or post-pregnancy if you know the early stuff? Is that all that matters? So where does the risk of CVD originate? That's really the question. And so here's a little bit of data from our group, but this really is just a little piece, drop in the bucket of the data out there. This is work by Anne Rolfing, who is a resident at UCSF and then a palliative care fellow. She looked at early pregnancy CVD risk factors in a California cohort of about 1,000 women who had their CVD risk factors measured prior to pregnancy and also in terms of cholesterol early in her pregnancy. And so we sort of tried to leverage that and look at whether these pre-pregnancy factors and early pregnancy factors could be constructed into a risk score that predicted preterm birth, which is again a adverse pregnancy outcome in women related to later CVD. And we were able to show that smoking, having either chronic hypertension or preeclampsia, having diabetes, meaning type 1, type 2, or gestational diabetes, having, her total cholesterol level and LDL level were independently related to the onset of either early preterm birth or late preterm birth. And we constructed ROC curves or calculated C statistics that essentially showed that you could predict preterm birth with C statistics of 0.6 or 0.686. And remember that most of our risk models, like the ASCVD risk score, just to kind of as a gut check of where prediction falls for most of our risk scores for CVD, it's around 7.73. This is, of course, a different outcome. We're trying to predict preterm birth here, but these C statistics are, sort of fall in a more modest range. So what does this all mean? Probably early pre-pregnancy factors do predict adverse pregnancy outcomes. So that's one piece of the puzzle there. And what about having the adverse pregnancy outcome itself? This is kind of a hard thing to study because you you really want to know, did the adverse pregnancy outcome somehow affect the trajectory of the CVD risk factor in women? And so this is data from Alyssa Eppel's study, the MAMAS cohort, which was a cohort of low-income women here in the Bay Area who did mindfulness meditation to try and reduce their weight gain during pregnancy. She had measured biomarkers in this study at 6 months before delivery, and then 3 months postpartum and 9 months postpartum. So we used that information to look at risk factor levels and trajectories for a number of cardiometabolic risk factors, and basically found that in the sort of highlighted in the red boxes, we found that glucose and systolic blood pressure trajectories were elevated in women with APOs. These are the women with the dark black line throughout the pregnancy, as compared to women with normal pregnancy in the dotted line. And you can sort of see that, so that the glucose level here, you can see sort of starts out lower and is about kind of parallels the normal pregnancy, but then around 3 months sort of accelerates. And so I don't know, I think this data is sort of hypothesis generating that having an APO actually probably accelerates a woman's risk in some way. So there might be epigenetic changes that differ in the adverse pregnancy versus the uncomplicated pregnancy that predispose the woman to a higher risk. And she, I believe, accumulates risk factors at a faster level. So this is data to suggest that the pregnancy itself may play a role. And then finally, this is just, sort of another reminder that we know that having the adverse pregnancy outcome definitely increases post-pregnancy risk factors as well. So I think that what we probably could say when we ask the question, when does CVD risk originate? It's likely pre-pregnancy, during the pregnancy, especially if the APO is pregnant, and it's probably post-pregnancy via elevated risk factors. So I think it's throughout that entire period. And I think that intervening at any point is probably pretty powerful. Intervening early is always where we want to do it, though. And what about reproductive factors? Well, I showed you this J-shaped curve. There's this really slight elevated risk for nulliparity, 0, and for primiparous women who've had one pregnancy. We were interested in that. What would that be from? We hypothesized this could be impaired fertility from PCOS, thyroid disease, maybe psychosocial contributions like depression or anxiety, maybe. There was this evidence that menstrual irregularities was related to CVD from the Nurses' Health Study, as well as Kaiser, and then we showed that in the Women's Health Initiative as well. And menstrual irregularity is a proxy for polycystic ovarian syndrome, and it's also related to infertility. So we asked the question in the Swedish registers, is subfertility or infertility related to CVD? These are the age-adjusted rates of cardiovascular disease for every year that a woman experiences subfertility. These women went on to have a successful pregnancy, so that's why I'm calling it subfertility rather than infertility. I don't think anyone uses that word except for us in this paper. I'm sure no one can even find this paper, but you guys are, because you're here, you're hearing about it. So you at least are learning about it. In any case, these are the age-adjusted rates. So you can see that for every year of subfertility, there's this dose-response relationship with CHD. And when we looked at categories of subfertility length, we found that if a woman had 5 or more years of subfertility, she was at about a 24% increased hazard of CVD. But the other, having 1 or 2 or 3 or 4 years, didn't really increase her risk. And Dr. Moriguppen from Stanford, she's a reproductive endocrinologist there. She is actually taking this work forward and looking at causes of infertility and also adverse pregnancy outcomes and how they interface with infertility and CVD in the Women's Health Initiative. So I'm looking forward to her findings there. So I think now that I've sort of shown you all of that, hopefully we can start to be a little more sophisticated with our stress test paradigm and really look at, when we're thinking about both the mother and the baby, there are probably factors before the pregnancy that also sort of intersect with the information we can get at the pregnancy, things like breastfeeding, menstrual irregularity, also the actual adverse pregnancy outcome itself in the mother, and her age at menopause. I didn't go over that data, but that's also a very important factor for women. An early age at menopause is a predictor of CVD. And then when you think about baby, has baby been breastfed? Because that's going to protect mother. The age at first birth, so having a non-teen pregnancy is protective for CVD in women. We don't know why, but we've seen that. Also, that all of these factors in green predicts CVD, also in the baby. So really, you can look at this stress test paradigm for as a stress test in the mother as well as in the child. And that's really the point I wanted to drive home with this. And now, knowing this information, which risk factors are important and which can we target. Again, this is the third time I'm showing this, not because it's the most earth-shattering thing, but this is really the most actionable thing that we have, I think. So if we know a woman has one of these APOs, we also know that she's at very high risk for elevated blood pressure. So I think doing all of the due diligence with prevention is important in these women. We know she's at risk for hyperglycemia or diabetes and dyslipidemia. So making sure we're aggressive with the time points at which we measure dyslipidemia and to, sort of do the lifestyle changes to prevent the onset of high blood pressure and diabetes. These are very important things, I think. We also, this is another figure from our statement. We also made the point that women at this point in time are seen postpartum at 6 weeks after a delivery. And this includes women with adverse pregnancy outcomes. And then they're sort of left to their own devices to see their PCP. So we sort of advocate for this better handoff between the OBGYN and the primary care doctor and say, listen, that first year after pregnancy is really like almost like a fourth trimester, and make the point that not only like 6 weeks just isn't going to cut it. You need to see the woman 3 months later, 6 months later, and a year later. And we need to sort of make that handoff a lot more seamless, because this is really where women are falling through the cracks. And it affects her later risk of CVD, and it probably affects her next pregnancy, the health of her next pregnancy. So there's lots of potential impact you can have if you change your paradigm. Not only do we need to do this as providers, but we need to get the payer system to actually pay for these visits. So there's a lot of different places that we have work to do. So in conclusion, pregnancy, maternal and fetal outcomes, as well as reproductive factors, predict later cardiovascular disease risk in women. They're actually risk enhancers, and I'm sure many of you have heard that term. It comes from some of our prevention guidelines, but risk enhancers are factors that help us better tailor statin therapy if we're on the fence about it, or if our patients are on the fence about it. So I take a history of the factors I mentioned because I use them as risk enhancers to help me better make a decision with my patient and help in that shared decision-making process. In Apex, feel free to please steal the template called CVPregHist.CVPregHist. It's smart text in my Apex Epic smart phrase directory. So please take it and use it. It summarizes all in a really short way. I think it's not very cumbersome. It sort of will allow you to take this history seamlessly with just kind of clicking through, and kind of encapsulates all those factors that took me the whole time to talk about, but this is very short. Shouldn't take you more than a couple minutes. I wanted to conclude that the CVD risk, hopefully I convinced you, likely originates pre-pregnancy, in pregnancy, and post-pregnancy. It's probably a 3-hit thing, honestly. And that identification and treatment of these factors are important for primordial prevention to prevent the onset of the risk factor, and for primary prevention to prevent the onset of cardiovascular disease. And then finally, wanted to acknowledge a bunch of people and to say that to do this type of work takes a lot of collaboration. And I actually do have some disclosures, and those that the fact I had 3 kids are my disclosure. And I did have gestational diabetes with my last one, that little guy over there. So I do have I do have a disclosure. Anyhow, love to take questions.
Thank you so much, Dr. Parikh. That was amazing. We have some questions from Dr. Goldschlager, so I'll go through. The first one, she wanted to know, what do we know about pregnancy and spontaneous coronary artery dissection? I'm not sure if it's specifically talking about how you counsel women who've had a history with SCAD, but Dr. Goldschlager, I'm gonna actually allow you to ask your question live, if that's okay. Let's see.
Can you hear me?
Yeah.
Okay. I just wanted to know if we know anything about pathophys.
Well, with SCAD, I wouldn't say we know a whole heck of a lot, but I think there's this association that we all worry about with increased levels of estrogen, and that occur during pregnancy, and also that we see sometimes with at least case reports of SCAD happening with hormone patches or women on birth control and things of that nature. So in terms of pathophysiology, I wouldn't say we've made tons of gains, but I think SCAD is being a lot better studied now. I know that there are very large case series out of Mayo and other places that are at least helping us understand the epidemiology of it. I know in our PACT clinic, in the pregnancy clinic, we usually counsel women not to get pregnant again if we know they have SCAD, or not to get pregnant if they have SCAD. Sometimes they listen to us and sometimes they don't.
She also had another question about whether or not arrhythmias during pregnancy predict APO or predict cardiovascular disease long-term.
That's a great question. I don't know if we have a lot of data on that. But that would be a great research question, honestly. At Up to Date, I inherited all of the arrhythmia topics and noticed that that definitely, there's a lot of unanswered questions around pregnancy and arrhythmia.
Thank you. I was wondering, you talked a bit about subfertility and its association with increased risk of cardiovascular disease in the future. So I wonder, how do you think about multiparity being an increased risk for APOs, but subfertility also being an increased risk of future cardiovascular disease? Or does that just kind of demonstrate that we really have so much more to learn about the interface of pregnancy and cardiovascular?
Yeah, I mean, we always want it to be very simple. And I think if it was a linear association, that meaning if parity or number of pregnancies was related to CVD in a linear way, it would be just like a cleaner story. But I think that, as my husband would say, women are very complicated and there's no simple answers with us. So I think that, I think fertility itself is just very interesting, honestly. I think it's really, on the sort of left-hand side of that J-shaped curve, I think we're thinking about fertility as almost a fitness test for women. And, the good news, I think, with that side of the curve is that the associations are very, very modest. Like the hazards, if you looked at, were like 1.1. So it's a very modestly increased risk compared to like 5 or more women, or the multiparas. Who might even show like a 2-fold increased risk. I have to be honest, I think that much of that increased risk in the multiparous women is unmeasured confounding, honestly. I don't know how much of that is actually driving the association. So I think that we're unable to perfectly measure for confounding.
That makes sense. I'm looking to see any other questions. Please feel free to drop them in the chat or raise your hand. I'm happy to allow people to answer their questions or ask their questions. live. Here we go. Oh. Hi, Dr. Goldberger.
I wanted to know if you're treating hypertension, Nisha, what is your antihypertensive of choice and why? And are there specific antihypertensives that you would not use?
During pregnancy, Nora?
Yeah.
Yeah, that's a great question. So, and a very practical one. I think that it sort of depends on how hypertensive they are. If they've got a good deal of hypertension and they're kind of difficult to control, I think labetalol is probably a very reasonable agent because it has sort of a really wide range in which you can give it, and it tends to be pretty good for the higher stages of hypertension. You can use beta blockers as well as calcium channel blockers. You must stay away from ACE inhibitors and a lot of the usual things that we reach for. Those are probably beta blockers and calcium channel blockers are kind of my go-tos, with labetalol being one of the ones that I reach for it if the hypertension is more difficult to control. And in the postpartum setting, if I think the woman's going to get pregnant again, sometimes we make a switch. And if we're in close contact, we hopefully are, and many of these women are actually pretty good about following up. Then sometimes we'll switch in the interim between the pregnancies to sort of our normal array of agents. And then we'll go back to, if she's trying to get pregnant, we'll go back to sort of the assumption that she's going to get pregnant and then switch her back to like the pregnancy regimen for that.
So I really love that you have a dot phrase for pregnancy history. And I wonder do you envision any other changes that we could probably instate to improve our appreciation of the effects of obstetric history in cardiovascular disease?
Do you mean like system changes or?
Yeah.
Yeah, I think we don't use the electronic we don't leverage the electronic medical system the way we probably should. I think that for instance, we've talked about this in our PACT program, our pregnancy cardiac treatment program, about putting in almost like automated healthcare language and transitions to provide healthcare information at the time of delivery. At the time of discharge after labor and delivery. For women who've had an adverse pregnancy outcome, just so it's on their radar right away. I think it tends to be a time period where women are really more thinking about their baby rather than themselves. But if you introduce the concept that, okay, yes, you want to take care of baby, but you also have to think about your own health. Like if you've had gestational diabetes, you have to come back and get an OGTT again, and you need to get really frequent monitoring of your glucose and hemoglobin A1C, et cetera. If you had hypertension in pregnancy, we want you to, be closely monitored for that. We're not leveraging our mobile technologies either, ambulatory blood pressure cuffs, things of that nature. And that those could be automated is my vision, in your after visit summary at the time you're leaving the hospital after you've had your baby. That could be the perfect time to have some of this information and follow up. I also think there are some centers doing follow-up clinics for women with APOs. I know MGH and Emory have such clinics in place, or they're starting that type of things. And I don't know if many of you have heard of this whole concept of cardio OB. It's really its own field. And I wouldn't be surprised if we have fellowships in it going forward. So I think it will be the new cardio onc, if you will. So that's very exciting as well.
I have another question from Dr. Goldschlager and then also Dr. Can.
Thank you, Nora.
Yeah, this is practical stuff. I need to know. We need to know. We often are sent or are consulted on dilated cardiomyopathy. So cardiomyopathy of pregnancy. They cannot take guided medical therapy for reasons you've alluded to. How do
Yes.
we modify if somebody is coming in on ACE, spironolactone, etc.? The beta blocker and calcium channel blocker, fine. But if they have an EF of 30%, what should we do there?
Yeah, that's a great question. Well, Lasix is okay. So if they get volume overloaded, you can use that. The nice part about pregnancy in some ways is the SVR usually drops. And so sometimes that bit of ACE inhibitor they were on can, you can drop it and not need to put them on anything else during the course of pregnancy. And you don't necessarily need to replace it with anything during the pregnancy. These women, though, if they do have the dilated cardiomyopathy, and this before they're considering getting pregnant, we usually counsel them not to, especially if it's in a severe range. But that being said, there have been women that we've successfully gotten through pregnancy. Oftentimes we bring them in very early and they're on bed rest, and we're sort of more closely monitoring them. I didn't talk a lot about pregnancy itself, but that's probably a whole nother topic. But the other factors we think about very heavily are the labor and delivery plan. And we discuss it early and often. So by that, I mean, the first time we meet them when they're pregnant, even if they're, like very early in their first trimester, we talk to them about their labor and delivery plan at that point, because they very much have an idea of how they want it, but it might not always coincide with the safe way to do it. For instance, maybe they want a vaginal delivery and they want to push, but that might not be the safest thing from their standpoint or the anesthesia standpoint for them, or their OB standpoint. So those are things we discuss very early. What kind of birth is it going to be? Is it going to be planned? Is it going to be a planned induction, for instance? At what point are we going to do it? Is the baby growing well enough throughout the pregnancy? Are we going to have to do it earlier to get the baby out and do the best thing for the baby or the best thing for the mother? So those are all parts of the multifactorial, multidisciplinary approach that go into the pregnancy cardiac treatment plan.
Can I ask one other thing, or are you throwing me away?
Yeah, no, I love that you're asking questions.
There is somebody else, but I have another Zoom, so you'll be pleased to know that.
No.
We've been reading, I have been reading lately about depression, postpartum depression. And there's all the rage about depression itself being a risk factor. You can't really get to that, but it would be a reason, it seems to me, to have a postpartum clinic. Is that something that you could, what do you think about depression being a risk factor?
Yeah, I didn't go over. So Rachel Spencer has sort of taken on a project. She's a fantastic resident. We've been trying to convince to go into cardiology, probably unsuccessfully, or maybe successfully, I don't know. But anyhow, she's been working with us on a project looking at postpartum depression as a risk factor for CVD, and it turns out there is a relationship, but it's just very poorly studied, in the sense that this might be the only paper we've seen out there on it. So hoping to get that work out there soon. I think you make a great point that if we were to have a postpartum clinic that really was more holistic, that might be the more powerful approach to treating women postpartum, where you're able to sort of attack their cardiometabolic health, their psychological health, because all of that really plays together. And I think that probably that's the way it makes the most sense to see women in an interdisciplinary way.
Thank you so much, Nora. We have a couple minutes left. I'm going to have Dr. Ganz ask his question.
Oh, okay.
Hi, Dr. Ganz.
Hi, Nisha. Hi, Joe.
Hi.
Great talk. Really
Thank you.
Great research. Great research underlying it. Wanted to ask you, for the last few months, I've been working with the cohort you may have mentioned, the new mom to be.
Oh yeah.
With Philip Greenland, he got $1 million for us to do proteomics in the first trimester to try to see if we could predict some of the adverse pregnancy outcomes later in pregnancy. And so far we haven't found as much as we hope to, which led me to the question: were we looking a little too early when we are looking kind of within the first trimester? So the physiology that you described in preeclampsia, with the spiral arteries kind of abnormally growing in the placenta, is that a first trimester? Is that a first trimester event, or is this a problem later during pregnancy?
That's a great question. I probably don't have the perfect answer for you. I know that preeclampsia itself presents much later than the first trimester, although the holy grail is what you're doing, which is really to try to predict it as early as possible. But my gut sense would be that you would have to do proteomics, like not maybe in the circulating blood, but maybe in somewhere else closer to the where the implantation's happening. So maybe like amniotic fluid or something like that to detect something very early. That's like my gut feeling about it, but I'm not basing that on data. Do you have second trimester blood? It might not be maybe what they were hoping for, but maybe you could get a signal in the second trimester and then go back and do something more targeted in the first trimester. Maybe would be a thought.
Right. I think it would be rational to look at the second trimester, and I know that there are many proteins during pregnancy that are expressed in the second trimester and not in the first trimester. So we may have looked a little too early.
Yeah, that's.
But
definitely...
there is blood available in all three trimesters in that cohort. So we may have to look a little bit later.
Yeah, I would say like maybe you can do like the whole panel later, and then I don't know, maybe if you can, I know how these things sometimes go. Like if you can identify a few, maybe see a signal earlier or something. I don't know, but that's those were my thinking about it.
Well, again, great talk, really great.
Oh,
great talk.
Thank you.
Great body of research. Thank you.
Okay. Well, thank you, everyone. We're just out of time. Dr. Parikh, thank you. It's always wonderful to hear from you.
Thanks.
And for everyone's reference, the recording will be available on our YouTube page, and hopefully I'll see some of you guys around.
Okay, bye. Thank you.
Take care.